So why, having done ultrasound, did I then get an interest in fluoroscopy? I started becoming more interested in pain management. And part of that was because I was reading and hearing about different pain management techniques. So a lot of it tends to be in terms of ablations, in terms of, reducing pain by knocking out things. And what we're actually doing is we're suppressing pain. But by suppressing pain, we're suppressing one of our instinctive protective mechanisms. And by doing that, are we then opening ourselves up to further injury later on? So really, it was having seen patients with back issues and back pains and chronic pain, and that's what triggered off my interest. And then after looking around, I found out that in Europe, pain doctors are starting to do regenerative treatments for pain and back pain, and they're even doing stuff for the disc as well. If you're interested in learning about interventional pain, so Agnes, she's the course leader that on the program that I went on, and Andrea, they put together this very nice book. It's pretty comprehensive. It is a bit exam focused, but it gives you a good foundation in terms of the ins and outs of fluoroscopy and interventional pain. It does cover everything from top to SI joint. I wouldn't say toe because it doesn't cover the lower limb. But I think if you have an interest or want to read up a little bit about interventional pain, I think it's a good starting point. And certainly if you have any experience in fluoroscopy already, and you want to just kind of expand your horizons a bit, this is very useful. So in terms of the treatment areas, these are the things that are covered in the book. So as you can see, it's pretty comprehensive. Everything from epidurals to facet joints to pterygopalatine ganglions, stellate ganglions. I mean, certainly when you go and learn those things, it's a little bit scary because you're doing injections into the head. But I think for the most part, things dealing with the C-spine, the thoracic spine, and the lumbar spine is right up our street. And I think we should, if you're at all interested, we should be upskilling in those things as well. So this is a fluoroscope. The X-rays are sent from the top to the bottom, and this is the receiver. So this is the X-ray tube. We're also trying to minimize the spread. So essentially, when the X-rays hit a particular area, they ping away, and what we're trying to do is trying to minimize the exposure to ourselves. There's a couple of positions that are very relevant in adjusting the fluoroscope. So obviously we have the PA view, we have the lateral, and when you're giving instructions to your assistants, it's important to tell them which way you want to orientate it. So you can have a chordad, you can have a cephalad, or you can have an oblique. And essentially what we're trying to do is take a two-dimensional structure, adjust another two-dimensional image, and see things from particular angles. And so although you may be quite familiar with the anatomy of different areas, trying to get your head around that in a rapid and functional way can be quite challenging. There's a whole variety of different treatments that can be done as well for this. Of course, you have RFA. They have cryotherapy as well, which is, I think, a fantastic treatment. And if any of you are interested in finding out more, do let me know. I think this could be a game changer in terms of pain management. There's traditional steroid, and here I have triamcinolone and DEXA, but it's always DEXA that we use for the spine. And then we have the regenerative stuff. So we have the PRPs and the Prolotherapies as well. And these are being used a lot around the world for back pains and regenerative medicine perspective. So let's have a look at C-spine epidural first. Now, in this, you have the patient in a prone position. You flex their neck to try and open up the neck a little bit. Start off with an AP image, and then you can go for a bit of cephalo tilt of the C-arm. You tend to enter the skin in a paramedian, so you're going to the side of the spinous process a little bit. And what you're aiming to do is you're aiming to touch the lamina, okay? The inferior border of the lamina. And then as you touch that, you walk off, and then you can get into that epidural space. You can confirm your position with a contralateral oblique. So essentially, if your needle is on this side, on the right side, you're looking from the left side to see, because the C-spine has a triangular shape. And as you come in this side, you can then see how deep your needle is from the opposite side. So this is some images. So we can see the diagram here. You can see the spinous processes. You can see the lamina. Okay, and then you can see the facet joints and everything there as well. So we get this image, our needle goes in, and we're touching onto the lamina. So fluoroscopy is very tactile. You have to appreciate what your needle is tapping against to be able to guide it as well. Whereas obviously with ultrasound, there's direct visualization. With C-spine, there's obviously a bit of a delay in getting the images. So once you've touched onto the lamina, you have your interlaminar spaces here, and then basically what you do is you very gently, you kind of walk your needle off that lamina, and then you get into that interlaminar space. And once you're into that interlaminar space, you might feel a little bit of a pop or a give, and once you have that, then you have a look from the opposite side, an oblique view, and you use some contrast to see whether you're in that epidural space. Now, of course, one concern here is the ligamentum flavum isn't particularly thick. You're very close to the spinal cord. But actually it's quite safe, done carefully, and if you are having patients with very long-standing neck pain, it can be a very useful technique. Lumbar facets, so as I spoke about earlier, I think it's very, very useful, and again, this is something that I use regularly. You have the patient in a prone position again, you take an AP view, you have to do this phenomenon of squaring off the vertebrae, so basically you're trying to see the whole vertebrae in one view. And then what you do is you go for a ipsilateral oblique, so the same side. You enter the skin at the lower third of the facet, and you're trying to achieve something called a coaxial technique, which is basically where you're seeing the needle in the tunnel vision of the fluoroscope. And as you enter into the facet joint, you feel this popping sound, and then you can confirm it with a lateral view. So this is the Scotty dog. So if you all remember from medical school or from training, you have the Scotty dog, okay? And so what we're aiming to see is this Scotty dog. So here on the fluoroscope, you can see the Scotty dog, okay? And so what this means is on the one part here, you see the superior articular process. On the other part, you see the inferior articular process, and you're aiming for the gap in between. And so this is the coaxial view. So your needle should be as in line with that fluoroscope as possible. And then once you're in the facet joint, then you can inject some contrast. But remember, of course, the facet joint is very, very small, and you can't really get a huge volume in. So if you fill it with contrast, you're not going to get the good stuff in. So just be mindful of that if you decide to go ahead with that. Okay, sacroiliac joint, again, inferior approach, having the patient in a prone position, AP view. Now, the SI joint is a little bit tricky because the anterior part of the SI joint sits more lateral, and the posterior part sits more medial. What you have to do is you have to go for a contralateral view. So instead of looking this side, you look from the opposite side, and you're aiming to see the SI joint portions kind of overlap a little bit. So here we have the AP view, and you can see that the different portions of the SI joint are overlapping because they're sitting, it's a three-dimensional structure, it's a two-dimensional image, and they're overlapping. And so what you have to do is you have to bring your fluoroscope medially and look outwards, and until you get the two portions of the SI joint overlap. And this is just to emphasize that. So the posterior portion sits more medially, the anterior portion sits more laterally, and so you're looking from medial to lateral view to see the SI joint. Again, once it overlaps, then you can go into the lower portion of the SI joint, and this is what I was saying. If you go for up at the PSIS, you're not really going so much into the SI joint, but it's the lower portion that's important, and you're looking to get the needle in coaxial view as well. Okay, lumbar transforaminal. Now, this is akin to the using the ultrasound. We call it a periodicular injection. So again, you have the patient in a prone position, AP image, you square off the vertebra, use oblique, so you ipsilateral oblique, and you're trying to open up that foramen. So obviously the patient is stationary, but by adjusting your image, you're trying to see a bit more. And essentially what you want to do is you want to oblique enough so that the spinous process appears to be on the other side. And there's two approaches you can take. It's either above or below the needle. And these are considered to be the safe approaches. You don't go directly into the foramen, because then you'll go directly into the nerve. And so this is on the diagram, this is what we're aiming to see. So you're looking at the articular processes here, and then this is the foramen here. And on the fluoroscope, what you can see is the spinous process is sitting over the other side. You can see your articular process. You have the vertebral body, and then you're aiming for either up here or down here. So that, remember, the nerve root as it comes out, it moves inferiorly and laterally, and so you're trying to get around there. Personally, I tend to go to the superior portion, because I feel that I'm more comfortable getting there, whereas I know other colleagues who go for the inferior part. And so these are your targets, so either here or here. And then what you do is you have a look at a lateral view. So it should be ideally a true lateral. So again, you need the structures to be overlapping, and then you should be able to see your needle in that foramen. And if you're around here in that middle portion, you're too close to the nerve. You then give a bit of contrast. You should see the flow nicely along that nerve root, and then you can give them the treatment that you want to give. Is it without risk? No, there's lots of risk. These are some of the risks that can be associated with fluoroscopy. So ranging from dural puncture, you can give intrathecal medication, there can be nerve injury, infection, bleeding, all of these things that can happen. But in all fairness, a large portion of these things can happen also with the ultrasound-guided injections that you guys are doing on a regular basis, and that I do as well. And so actually, yes, there is a bit more risk with the fluoroscope and with the spine treatments, but I think if you do it with due care, training, consideration, and select your patients correctly, I think it can be helpful. Mitigating the risk, it's important to select the patients carefully, teach them and educate them before the treatment. Look at their comorbidities as well, and medications. So if they're on anticoagulants, you need to switch them off it for a period of time, and so on. Look at your treatment environment as well. So I was previously doing, at KTP, I used to do spine injections in the outpatient setting, which is quite achievable, and certainly I can do that in the clinic as well, but because since I left, I've been privileged to have access to the OT setting, and so there's many more safety measures available, and more checks and balances as well. And certainly one of the things that are important is doing observations and safety netting. And as with all interventions, actually, I think checking your blood pressure, heart rate, oxygen sats is important. Certainly after pain procedures, or any procedure, in fact, even if you give a HNL to somewhere, or hyaluronic acid, blood pressure can spike. And so it's not isolated to just the stuff that I do, and it's not just isolated to spine stuff. It can happen with all treatments. So checks in place is important. And ligaments. I mean, I know I spent a while talking about ligaments, but please do think about this when it comes to dealing with back pain, because I think if you're not considering it, I think we're missing a bit of a trick. But thank you very much.